So we are already in week 7. Time is flying by. So you guys already have your midterm. Is everybody that is online right now registered for your midterm?
Yes.
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 I have one
Yes.
person, and I don't want to call her out in front of everybody. I have one person in my class that hasn't registered. And actually, I don't see her online, so I can't even call her out. So everybody that's in my class, I know that is, you guys are all registered. You're good to go. Do you guys have any questions? Because I know this is your first ProctorU exam. Have I kind of killed it as far as what you guys need to do as far as trying to have as blank of a room as you can, have your ID. I think it has to be a driver's license. I don't know if like a work badge works, but some kind of photo ID that you're going to scan for them. Try to sign in like 15 or 20 minutes early so that if there are any technical difficulties, you guys can go through it. And nobody registered for the very last day, right?
No.
Actually had
I
to.
did it before.
Okay, day before. Who did have to register on the last day?
I did for
Where
Monday.
my work schedule is.
Dang it, Sarah Brown. You still
I
haven't
know.
changed your name.
No, yeah, I haven't figured that out either. I'm a mess.
Well, that's why you had to register for the last day if you can't figure out your name.
I work weekends, and so like the day I could take it the day it opens, but I don't want to.
Gotcha. Okay. And just, I mean, it's the midterm, so it's not as big of a deal. Just try really hard not to do that when you guys get to your final, because I mean, it never fails that somebody has an issue, like a proctor doesn't show up or something beyond your control, and then we're scrambling at the last minute. So just try not to make it on the very last day. Midterm, you have more leeway. So Sarah, I'll let you get by with this one. Okay.
And also, how do you not freak out?
How do you not freak out?
Yeah.
So this is just a test. Like if you guys were sitting in my classroom and I'm walking around, like don't think of it as any more or less. If you are here tonight and you pay attention to the last half of tonight, I promise you, you're gonna be fine. I have not ever steered anybody wrong with my reviews. So if you come to my reviews, you're gonna be fine. Even better to attend like all my lectures leading up to my review, but especially if you come to my review, you're gonna be totally fine, okay?
You know how to change my name?
And hey, Josh, how are you?
Apparently, I just had to right click over my profile and it's right there.
Well, I'm glad we got one of two things figured out.
There you go, right? I'm almost there.
No, you guys will be totally fine. It's just a midterm. Can you write notes while taking the test? So you can have a blank piece of paper. You're going to have to show your proctor that this is a blank piece of paper and a pen, so that if you do write anything down, they know that you are writing it down. You're not looking at anything that was already written. So you can have a blank piece of paper and a pen on hand when you take your exam.
Are you able
And
to
how long is
go
that exam?
back
Oh.
or only move forward?
Oh, Elizabeth, that was an awesome way to bring that up. So you can flag a question. Okay, so you can say, I don't know how to do it because I've never had to do the proctor test, but there's a way that you can like mark this question so that if you have time, you can go back and go to those just marked questions to either rethink them or whatever. So one thing that I recommend, if you do flag a question, I would still answer it. Don't leave it blank just in case you run out of time. I don't want you to have a blank answer that you might as well at least guess and try to get some points, right? You will have some that are select all that apply. Only if it says select all that apply are there going to be more than one correct answer. If it doesn't say select all that apply, there is only one right answer, or there is only one best answer, because you know how we love to make questions hard like that in nursing. Beverly, you don't have to scan an ID. You're going to take your video and you're going to show your ID in front of your video. That's what I mean by scan. Like you don't have to have a scanner or anything like that.
They're going to look like the quiz number 5.
Caitlin first, what'd you say?
Is the test graded right then and there?
Yep, you're going to know as soon as you finish. Yes, you're going to know your grade. You will not know which ones you missed. And just to save the integrity of the test, we can't go through it unless you guys schedule an appointment. And you just do that with whichever professor you have, and they can take some time and meet with you, do a Zoom meeting to go over what you missed. I usually go over once, so we can't do it next week because that's the last day, but we can do it the following week, where when we're done with lecture, if you guys want to stick around and you guys can individually, as long as you don't care about other people knowing, we can we can go over questions too. I just can't pull up the test for you. What were you going
Just
to
to
ask?
clarify, you don't have access to the other classes test, right?
Correct. Yeah. So make sure whoever is your professor, because you're Tyner, right?
Right.
So I did let Melissa know of what you guys told me, and Melissa was going to talk to her to correct that because I think it was just something that she wasn't aware of. So hopefully that's fixed.
Thank you so much.
No problem. Josh, what were you going to ask?
The test bank is the same one as quiz 5. It's going to look similar to that. I'm guessing. Is that right? Or
Yeah. Yep. This time it's just going to be close your book. That's the only difference. And tonight's review is going to be kind of long because how many questions do you guys have for your midterm? 50?
50.
And how long do you get
I
an
think
hour?
an hour and something, I think it said.
Yeah. 15 or hour and 5. something like that.
So you are going to have an hour and 15 minutes for 50 questions. The questions all come from a bank of questions, and I don't know which bank of questions each person's going to get. So for our review tonight, I go through everything with you guys. So luckily our lectures tonight are kind of short, if I recall, because we're just doing mood disorders and pain tonight, right?
Yes.
Mhm.
So tonight's lectures are pretty quick, especially our mood disorders. This actually used to be part of last week, so we would have actually already had this part done. But we'll go through these quick and then we will do the review unless you guys have any other questions about ProctorU. Feeling good?
Feeling good.
Good. I like to hear it. And I would love to do the review for you guys first, but I want you to actually listen to my lecture too, so you don't get to. Sorry. All right. So we are going to open this guy up and share this guy for you. So you guys should all have mood disorders up on your screen, correct? Okay. And I tried to make this one pretty for you, just to mix it up a little bit. All right. Let me get you guys out of the way. All right, so first mood disorder we're going to talk about is schizophrenia. Schizophrenia is a serious mental illness that affects how a person thinks, how they feel, and how they behave. An easy way to remember schizophrenia is it's almost as if they've lost touch with reality. This is usually going to be diagnosed late into the teen years, all the way up into your early 30s. In males, we see it emerge even later, so late adolescence to 20s. Then females can be early 20s to early 30s. So usually schizophrenia is going to be diagnosed after they've had an episode of some kind of psychosis. So first they're going to have symptoms. That'll usually be the first symptom of schizophrenia. I had a good friend of mine that was super responsible, like went to work, went home to his family every night, saved money. And we actually didn't find out he was schizophrenic until his wife looked in the bank account that generally had about $15,000 in it, and it was empty. And he had no recollection or ability to account for where all of that money went. So that was when he first had that psychosis and was finally diagnosed with schizophrenia. We don't know what causes schizophrenia, but we do think it's a combination of genetics, your brain chemistry, and then your environment that are all going to contribute to you developing this disorder. Sometimes it can just be naturally occurring brain chemicals that go wrong. We do know the neurotransmitters dopamine and glutamate contribute to schizophrenia. You can see that in twins, we have the 30 to 50% in a monozygote. So that means they're coming from one cell. Dizygotic, then it's down to a 12%. So we definitely can see some kind of genetic prevalence there. We do know that there's prenatal and perinatal vulnerability factors. So women that are exposed to infections, any kind of nutritional deficiency. I actually just got done reading a book and I tried to find what it was and I couldn't. But they have found that most schizophrenics smoke. So when they smoke, it seems as if they almost stay in touch with reality a little bit better. So they've now been looking at how nicotine affects the receptors of the brain and have found that they can actually calm down schizophrenia. So they want to know if we can incorporate this into a woman's pregnancy, could we decrease the prevalence of schizophrenia? Obviously, we can't prescribe nicotine to pregnant women. So now nicotine is broken down into a smaller molecule, and I can't remember it right now, but they now put that inside prenatal vitamins. And so we're not going to know probably for, a couple of generations, since this isn't diagnosed into the 30s, but we might see that the prevalence of schizophrenia actually decreases now that we have this nicotine substitute into prenatal vitamins. So something that I thought was pretty cool when I just finished this book, but it's sad because these people have spent lifetime, like their entire lifetime, studying the DNA and how schizophrenia works. And by the time we figure out if we know if they've helped fix it or correct it, they're going to be dead. So I think that's kind of sad. But so with schizophrenia, we do know that there's those neuroanatomical alterations. We'll see enlargement of the lateral and third ventricles. We see a smaller thalamus. We'll see loss of cortical tissue and loss of levels of renin. So what neurotransmitters, so we see alterations in this brain dopamine, what neurotransmitters are going to be reduced in people with schizophrenia? P.S. If I'm asking you questions during our slides, they're probably going to be really important to know next week. Okay.
GABA,
GABA what?
right? The acid.
Yeah, so
GAB.
it's actually your gamma aminobutyric acid, or your so GABA, your GABA. It's short for gamma aminobutyric acid. That is what is reduced in people with schizophrenia. So here you have some neuroimaging. I don't know exactly what they're trying to show here, but we do know that the brain structures and the central nervous system of people with schizophrenia are altered. We don't really know what the significance of these changes are, but we do know that we can say that schizophrenia is definitely a brain disease. We do see findings that will show that we have generalized tissue loss as well as more selective focal loss in brain scans of schizophrenic images. Again, we don't really know how they reflect neurodevelopmental and neurodegenerative disease processes, but we do know that there are differences. Some have suggested that dopamine systems in one of these pathways can contribute to what we call positive symptoms of schizophrenia. If they have an excess of these dopamine receptors, this can affect the Broca area. And which area of the brain does Broca control?
Language.
Yeah, it's our language process. So if it affects the Broca's area in our schizophrenic, this can produce that illogical language. Sometimes we'll see a disconnect in the Wernicke's area. So that means they are able to comprehend language, but they're not able to create it on their own. So a lot of the mood disorders that we talk about tonight, we give antipsychotic drugs for like our schizophrenics. A lot of antipsychotic drugs are going to cause what's one of our big adverse drug reactions that we see with psych meds?
Tardive dyskinesia.
Tardive dyskinesia. Why does tardive dyskinesia, it mimics the effects of what neurotransmitter?
It increases dopamine.
Yeah, so anti-psych drugs cause tardive dyskinesia because they're going to mimic the effects of dopamine. Exactly. What was that, Natalie? I don't know if she was talking to us. All right, so schizophrenia, when I just said earlier, the positive symptoms, so that means these are usually not seen in anybody that doesn't have schizophrenia. So if it's a positive disorder, they're seen in only our schizophrenic patients. So some positive symptoms that we'll see, that psychotic episode, that this is usually how we diagnose it. They'll have hallucinations. So this can be without an external stimulation. They can have delusions, which is a false belief, but these will remain persistent, or they might just have disorganized behavior. Somebody tell me the difference between a hallucination and a delusion.
Delusion is a false belief
So give me an example.
Somebody think that they are pregnant, even if they're not pregnant.
Okay. And how would that be different from a hallucination?
Hallucination in which they hear voices or see something they are not actually seeing or
Yeah. And one way that I always just talk about it, so delusion, so a false belief is persistent. So a delusion would be, I'm God. I'm thinking that I am God. And this is a false belief, but it's going to stay persistent. Hallucination would be, I see God, unless, of course, I actually see God. But you could have that hallucination where you actually see a physical being and there isn't that actual stimulation, anything external happening. So delusion, I am God. Hallucination, I'm seeing God. Then are negative symptoms. So these are symptoms that a schizophrenic could have, or it could be some other disorder. These aren't going to be specific just to schizophrenia like our positive orders are. So some of our negative manifestations, we'll see a disruption in their normal emotional states. That can be a number of disorders, right? They can have some very flat affect. So they don't really have any kind of emotion with when they're talking. They're just very flat and monotonous. Anhedonia, so this is when they don't experience joy. Alegia is poverty of speech or avolition, which is a lack of motivation. Again, these can all be part of schizophrenia or some other disorder. We can also have cognitive symptoms where they have problems processing their thoughts, or they're not able to perform their daily tasks because they can't pay enough attention or plan for them. All right, if a person's admitted to the hospital after experiencing delusions, you know that a delusion is what? Number two, yeah. So this can involve something grandiose, something somatic, something sexual, something religious. But these are all going to be a delusion, something that's not actually there. So it's contrary to the background of the individual. So our unipolar or bipolar disorders, so these are all going to affect our mood, our affect. They're going to cause depression, and then we're going to have different categories of those mood disorders. So all of these are going to affect our hypothalamic pituitary adrenal system, or what we call our HPA system. So the HPA system is going to affect a large percent of individuals with what? What did I just say up here? Depression. So remember, when we're talking hypothalamic pituitary adrenal system, then we're talking major depressive disorder. Low levels of serotonin we know are associated with depression, anxiety, and then also sleep trouble. So a lot of doctors will prescribe what to treat depression?
All right.
SSRIs, right? So these are selective serotonin reuptake inhibitors. These are going to be your most common form of antidepressants on the market. So if we are giving selective serotonin reuptake inhibitors, we'll see a decrease in receptor binding for which neurotransmitter?
Serotonin.
Found in patients with depression. Yeah, so depression is always going to affect, remember, your serotonin. So unipolar and bipolar, again, we do know there's a genetic predisposition. We see it's a lot higher in twins. We do know that there is some environmental influences that can also affect these patients. So as far as our neurochemical dysregulation, we're going to see deficits in norepi, dopamine, and then our big one, serotonin. That's going to lead to depression. With our neuroendocrine, we can see dysregulation in that HPA system. We might see immune alterations, and then we can see hypothalamic pituitary thyroid disorders as well. So some of these will see that widespread decrease in the serotonin receptor. We can also see a reduction in what's a glial cell?
It's in the brain.
Yep, so glial just means it's a brain cell. So we actually see a lower number of glial cells in patients that have unipolar and bipolar. And we can even see a decrease in cerebral blood flow as well as glucose metabolism in some of those brain areas as well. So clinically, these patients will come in with just these feelings of overall sadness and despair. They might have a dysphoric mood. They might complain of insomnia, changes in appetite and body weight, or even suicidal thoughts. So any of these complaints, so the chief complaint of I can't sleep, we better be putting what as one of our differential diagnoses?
Depression.
Depression better be on there. So any of these clinical signs and symptoms, if these come up in your chief complaint or in our HPI, we better be adding depression on there. What if we have a patient that is on a psych drug and they become pregnant? Can we give psych meds to pregnant women?
I think it depends on what kind it is.
Depends on what kind it is. So what would be another option that we could give to pregnant women if we didn't have any medication options?
Electroconvulsive therapy.
Yep. So ECT is the only thing that we know that's safe for pregnant women. For our bipolar patients, so these patients are going to go through elevated moods of overall euphoria and happiness. They're going to have really high self-esteem. They're even going to have grandiosity. And then they're going to go through these times of very poor judgment where they might spend too much money. They might become hypersexual, and they're going to make really poor business commitments. When they come in, they're going to have that excessive, rapid, loud, and even pressured speech that you notice as well. If you had a patient that was on an MAOI, a monoamine oxidase inhibitor, what food would be most appropriate?
Ham.
Why?
I thought they couldn't have processed meats.
So let's talk through this. So what do what do MAOIs cause? What's a high risk of this adverse drug reaction with an MAOI?
With
What'd you say, Rita?
glutamine,
Say it again.
serotonin syndrome.
Could be at risk for it, yes, but it's not our most common. So MAOIs can cause really acute high blood pressure, even hypertensive crisis. If they take tyramine-rich foods, so foods like aged cheeses, sour cream, beans, liver, raisins, avocados, all of these things on here, except for ham, can actually, those are all tyramine-rich foods. So ham is actually the only one that they can have, would be most appropriate. These other ones we want them to avoid. Anxiety disorders are going to affect about 10 to 30% of the general population. A lot of these patients will develop major depression. So some examples of anxiety disorders are panic disorder, generalized anxiety, acute stress disorder. We can even see agoraphobia. What's agoraphobia?
People that won't go outside.
Yeah, these people are going to avoid places and situations because they're going to feel trapped. They're going to feel helpless. They might even have some kind of panic disorder when they're put in those certain situations. So with that panic disorder, they're going to have multiple attacks where they have just way too much stimulus, they're over aroused. When this happens, they're going to become lightheaded. They can experience racing heart. They might not be able to breathe. So with a patient with panic disorder, we might see them develop agoraphobia where they're not able to go into certain situations, or they might have to avoid places altogether due to it. So the risk is going to be nearly 20% if you have a first-degree relative that also suffers from a panic disorder. So we do know which chromosome, it's chromosome 11 that it affects. So we know that there is that genetic predisposition. Panocytogens can also cause physical symptoms, and we know that the amygdala is going to be very sensitive in any pH alterations. These patients are not going to be, so if we have reduced receptors, does this mean that benzos are going to work better or worse?
Worse. Worse more.
Why?
They
I mean-
can't take.
They can't process benzos. So.
Yeah, so the receptors are going to be all full really quickly, and most of that medication is just going to be free floating in the blood. It's not really going to be doing anything. So benzos may not work very well for these patients. If they have generalized anxiety disorder, this means that just all around they have excessive and persistent worry. We can see irritability and fatigue. We do know that they have norepi and serotonin abnormalities, and that GABA receptor is also going to be altered. PTSD, these patients have been exposed to something terrifying or some kind of life-threatening trauma, and then they experience intrusive flashbacks. This can affect them for their entire lifetime. We do know that the amygdala and the prefrontal cortex are going to be affected. And again, we see a decrease in those benzo receptors. OCD is going to be 10 to 12% more prevalent if you have a first degree relative that also has OCD. We know that this affects the basal ganglia. They have a lack of serotonin control. They're going to have repetitive intrusive thoughts and compulsions. They might have obsessions where they become completely preoccupied with something. This will be the patient that they have to tie their shoe 24 times before they can leave the house, or they might have to touch a door handle 3 times before they can open a door.
I'm familiar.
Are you an OCDer?
I have to check my lock every time I leave my house.
I think
Whole
that's just
times.
responsible parent. I think that's just being an adult, Paul. I don't know that you have OCD.
I don't know. I had to like twist and turn my door handle 3-4 times before I leave.
That
Or else while I'm driving to work, I'm like, did I lock the door or not?
that sounds a little more OCD. Mostly, though, I just like that you do lock your door. I feel like that's safe practice. I mean, unless you live in like Kansas or somewhere that people don't lock their doors. I don't know.
Paul, I do the same thing.
Okay, this is not me then.
So maybe you guys are just responsible adults.
Sometimes I have to drive back home and check again.
Oh, I did that a few times before.
Again, I think just you're responsible adults. I think we're okay. All right, we're gonna go right into pain and addiction. I don't even know what this slide is. I feel like this guy's gouging this guy's eye out or something. I'm not totally sure, but. So when we talk about pain can be, how do we describe it as nurses? Pain is what?
Subjective.
Completely subjective. And we always say it's whatever the patient says it is, right? Because my idea of pain might be totally different than your idea of pain. This is fun when we're in class because I do make you guys figure out who has the highest pain tolerance in our class, and we can't do that here, so that sucks. But some different theories of pain. So we have a specificity and a pattern theory. Specificity means that pain should be related to the amount of tissue that's actually injured. That's not a really good theory in my book because I work in pain. So a lot of times what we see and what the patient interprets doesn't coincide. A pattern theory means that there's an impulse or an intensity of a repeating irritation of the central nervous system. Again, this isn't going to account for all pain experiences. What we do pretty much all agree on is that the theories of pain are going to be controlled by the gate control theory. So this is going to show why pain is so complex. So pain is going to be regulated by a gate in the cells, and this is going to take place in the substantia gelatonosa within the spinal cord. So we have these large myelinated A delta fibers, and then we have unmyelinated C fibers. These fibers are going to respond to any kind of painful stimuli. So this could be mechanical, like crushing your finger. This could be thermal, like touching the stove, or this could be chemical, like maybe a drug or a toxin. Any of these irritations are going to open that gate. So once we have that transmission, those A beta fibers are going to close or partially close the gate. Then there's also the neuromatrix theory. So this is just going to give us more information on that, how that gate control actually works, and shows how those different nerve impulses are going to be variously input to up to our brain, how we have a different genetic component, there's psychological components, and then there's even the cognitive experiences, maybe things that we've experienced in the past that can make something seem more painful than it actually is. So this shows the plasticity, and this is how the brain is adaptable. This is one thing that I always talk to about my pain patients, that I mean, if you've ever done anything like stubbed your toe, and we know how painful that is immediately, that impulse isn't changing, but your pain will slowly subside, right? And nothing has changed except for our brain is very plastic, and it can start to adapt, like, okay, I know this impulse is coming, and make it seem not as sharp or not as bright. We do a lot of neuromodulation in my practice. And so one thing that we do is neurostimulation, where if we stimulate the spinal cord, we can actually block pain signals from being sent to the brain. But if we turn that stimulation off, I'll tell patients that they might experience, it's like a light switch where we've turned the light back on, and now those pain impulses can be resent, and they might actually seem worse than what they were before. So, and the only way I can ever compare it is if you turn lights off, your eyes are going to adjust to the dark. And you turn that same light on, it's the same brightness, it didn't get any brighter, but now your eyes can't even handle it, it's so bright. That's almost what we can do with neuromodulation and how it affects the brain.
Is that why people who have taken pain meds, if you take them off of the pain meds, their pain is actually worse?
Talk a little bit louder, Allie, because I think I like where you're going.
I was just thinking that, is that why people who are on pain meds, who are taken off of pain meds, think that their pain is actually worse than it was before?
Yep, and what we're doing then too is we are opening up all receptors so quickly that it can put them into shock and withdrawal, obviously. If we stop a patient's pain meds abruptly, can we kill anybody?
I would say yes, because I mean, opiates are related to our street drugs like heroin, which is life-threatening if they go through withdrawals abruptly.
So any kind of opiate, if we open up all of those receptors aggressively and intensely, we're not going to kill anybody. And this is kind of how I can take comfort in the fact of, like, if patients are non-compliant with me and I have to stop their pain meds, I mean, I'll be nice and I'll wean them off meds unless they're doing something like heroin, or a lot of patients now we know are positive for fentanyl. And I can't, in my right conscious, prescribe medications to wean them off if I know that they're also using fentanyl, right? Because I don't know how much fentanyl they're taking. I don't know where they're getting it from. But if I just stop a patient abruptly, obviously I'm going to try to get them into a rehab pretty quickly. I'm not just going to try to put them into withdrawal, but I'm not going to kill them. And that's a lecture that I have to have with a lot of patients, is your pain and your withdrawals aren't going to kill you, but overtaking opiates or taking fentanyl, we know kills people every 11 minutes in the United States right now. So flip that over to benzos that we just talked about with our psych drugs. If I abruptly stop somebody's benzos, can I kill them?
Yes.
If their depression gets bad enough.
No, benzos, if you abruptly stop, you can cause seizure withdrawal and you can kill somebody.
Oh, okay.
So you cannot stop benzos abruptly. You shouldn't stop opiates abruptly, but you can, and you will send somebody into withdrawals. And again, withdrawals not going to kill somebody. You could cause, maybe if they have comorbidities, you might cause, a hypertensive emergency, but that's what's going to actually kill them, not taking them off their opiates. So when we talk about the anatomy of pain, we're going to talk about afferent and efferent pathways. So afferent with an A are going to begin in that peripheral or that PNS system, and they're going to travel to the spinal gate in the dorsal horn, and then they're going to go up to the CNS. So afferent are away and traveling towards the spinal cord. Then we're going to have those centers of the brain where we interpret all those signals. Those are going to be in our brainstem, our midbrain, our diencephalon, our cerebral cortex. And then our efferent pathways, these are going to take messages from our central nervous system and bring them down to the dorsal horn. So afferent A starts away, efferent starts at the CNS and carries them to the afferent pathways. So we have nociception of how we process pain. So we're going to go through different phases. First, we're going to have transduction. This is when that actual tissue damage occurs. Then we're going to have transmission. So now that pain impulse has to go through those A delta and those C delta fibers and get into the dorsal horn of the spinal cord in order to be sent to our brain to say, ouch. Then we're going to have perception. And perception is when we finally have conscious awareness of pain. And modulation is when we're going to have that either increasing or decreasing signal, how our brains become a little bit more plastic with it. So how long do you think it takes to go from transduction to perception?
Not long. Second.
It's absolutely going to depend on the person, right? If I am somebody that has diabetes and I already have neuropathy and I have peripheral artery disease and I step on a nail, is it going to take a while for transduction to hit perception?
Yeah, it may never get there.
It may never get there, exactly. So that perception may never occur, and that's because we have an interruption in the transmission of it. If we're a normal, healthy person, hopefully as soon as we touch that hot burner, we're gonna say, ow, and we're gonna have a really quick transmission. And that's how our brains save us from keeping our hands on a hot stove, right? So those nociceptors, these are gonna be stimulated when we first have any of that mechanical deformity or temperature extremes. So that first stimulation is happening as soon as that tissue is going to even be touched or damaged. Then again, that transmission happens through our myelinated A and our C delta fibers. We also have the A beta fibers, which is going to be your bigger myelinated fibers that are going to transmit touch and vibration senses as well. Our secondary neurons and interneurons live inside the dorsal horn of the spinal cord, and these are going to be projection cells. These are going to be able to either excite or inhibit those inner neurons, and these are going to cross over the cord, and they're either going to ascend, they're going to go to our brain and give us information, or they're going to descend and send that signal away. We also have third order neurons that are afferent. So where are those?
Going away.
Those already are away. Remember, those are in our peripheral nervous system, and those are going to travel towards our spinal cord. So they start away. They don't go away. I know, I think I maybe made that confusing. But these afferent neurons are what's going to carry that information to our hypothalamus, our thalamus, and our limbic systems so that we can interpret those signals. So here's our primary, our secondary, and our third order neurons. So this is where I always do the experiment for you guys of your pain threshold and your pain tolerance. So your pain threshold is going to be your lowest intensity of pain that a person can recognize. So what I have you guys do is I take a big bucket of ice water and you stick your hand in it. When you first say, ow, that's your pain threshold. Your pain tolerance, that's your greatest intensity that the patient can endure. So when you have to take your hand out of that water, that's your pain tolerance. So threshold is, ow, this hurts. Tolerance is, okay, I can't do it anymore. And I did find out in Mexico at my last family vacation that my daughter, I think who was maybe 15 at the time, has the highest pain tolerance out of anybody in the family, which was super impressive. Turns out I'm the biggest wuss. So if we have intense pain at one location, then this can cause an increase in pain threshold at another location. How I describe this to my patients, so you might have a paper cut on your finger and that hurts really bad, right? But if I smash your toe with a hammer, you're going to forget all about this paper cut that hurt real bad a second ago. So that's just our body's way of changing locations. Same thing that when we do spinal procedures. A lot of times we can do procedures and I'll fix somebody's back pain and they come in and they're like, man, but now my neck really hurts. No, your neck always hurt. It's just your brain was more focused on the more intense pain of your low back. So now that we fixed your low back, you can actually pay attention to the pain in your neck. So we have segmental inhibition. This is where we have those alpha fibers stimulated as that impulse is carried across the A delta and the C delta fiber impulses. And this is where we have those inhibitory interneurons. And this is what's going to help decrease that pain transmission. So remember, we stubbed our toe, but 10 minutes later, it's not going to hurt as bad as when we just stubbed it. We have conditioned pain modulation. So this is if we have a diffuse noxious inhibitory control. So this means if we have just constant persistent pain, it's not always going to stay in our brain as a constant persistent pain. Our brain is able to kind of modulate that, and that's where that plasticity comes in, where we can kind of now tolerate something that maybe we couldn't tolerate it first because we become accustomed to it. We also have an expectancy related cortical activation. So this is patients, if I do knee injections often on them, so they know exactly what that knee injection feels like. Before I even uncap my needle, they can already feel that pain. And that's your brain's way of reminding you of like, oh shit, this hurt last time. It's probably gonna hurt again. So we have excitatory neurotransmitters. This is when that tissue injury and inflammation first occur. Our inhibitory is going to be our GABA and our glycine. Our endogenous opiates. So these are everything that our brains are capable of to get rid of pain. So when we're first have that stimulation, we're going to release endorphins. We're going to release dynorphins and endomorphins and even enkephalins that all help us tolerate pain. Do you think our endorphins, so these are endogenous opiates, or exogenous, like an Oxycontin, what do you think is more powerful?
Endorphins.
Endorphins are way more powerful. And this is, again, comes into a lot of my lectures with my patients of your brain will, have you guys heard the term hyperalgesia?
Yeah.
So hyperalgesia is when your pain actually seems worse than it is. And you'll see this in chronic pain patients that take chronic opiates. So if I am taking 4 oxy a day, and then I go get a paper cut, that paper cut is going to seem so much worse because my body has done nothing to control my own pain in such a long time, because that whole negative feedback system, right? I'm simply covering up all of my pain receptors with exogenous opiates. So my body is going to stop producing any kind of endogenous opiates like endorphins and endomorphins. So this is how I get patients off opiates is we have to slowly back off and we start opening up those receptors. When those receptors are open, it's going to say, hey, brain, I'm in pain, do something. We start releasing those endorphins and we can slowly back them off opiates. But they will experience what is called hyperalgesia if they stay on there too long. So here's the pathways that we just talked about if you're a diagram person and want to go through all of that. So let's go through the different types of pain. So nociceptive, this is going to be pain from a normal tissue injury from a known cause. So this would be an electrical burn, okay? What's the difference between somatic and visceral?
That's
Visceral
like
your
the
organs.
organ itself.
Yeah, so visceral is going to be any kind of hollow organ. So give me a type of pain that we would say is visceral in nature.
Pancreatitis, maybe?
Absolutely.
Gastritis.
Gastritis, for sure. So all of those just empty organs, if they cause abdominal pain, that would be a visceral pain. Somatic pain would be anything else. So if I crush my arm, that would be a somatic pain. Non-nociceptive pain is neuropathic pain. So we can have peripheral or central. So give me some examples of non-nociceptive pain. Neuropathy, for sure.
Mm-hmm.
What about spinal cord injury? Would that be neuropathic pain?
Yes.
Is it?
Absolutely, yeah. Classifications based on duration. So what do we consider acute pain versus chronic? When do we say it's chronic?
6 months or more.
3 months.
More than 3 months. So anything less than 3 months, we'll say acute. If it lasts more than 3 months, then it's chronic. So acute pain is going to be protective in nature. What it's doing is telling us that there is something that is harmful to our body. So, right, when we have our hand, we put it on a hot stove and we jerk it away, that acute pain is that protective mechanism like, hey, dumbass, get your hand off the stove, right? Again, if it's acute, that's going to be less than 3 months. It's still going to produce clinical manifestations where we'll see our heart race, our blood pressure is going to go up. We'll see diaphoresis and dilated pupils. Why is that?
Adrenaline.
Adrenaline. This is our fight or flight, right? This is everything kicking in of like, hey, get out of there. So acute somatic, this is going to be anything that we said, joints, muscles, bones. These are going to travel through those A and C delta fibers. If it's acute visceral, that's our internal organs and lining of the body cavities. Patients aren't usually going to be able to take like one finger and point to where their visceral pain is. It's usually going to be like right lower quadrant or left upper quadrant or left flank. It's going to be just kind of a generalized area. Referred pain is any kind of pain that they're having that is not at where the actual injury or insult is. So give me an example that we all know of referred pain.
Appendicitis.
Where will you have referred pain?
If you push on the right, won't it be over on the left?
So that could be a referred pain. So we do a McBurney's point where we're pushing down on the right, but they have pain maybe on the left. What's another one? Where do people have gallbladder pain?
In their left shoulder.
Yeah, so anytime they come in with a left shoulder, but they didn't have any kind of traumatic injury, some kind of gallbladder, cholecystitis, something should be on our differential diagnosis because that's a really common referred pain one as well. So some sites of referred pain. So here we can see liver is going to go to the right shoulder. The heart, we know, will travel down the arm. A lot of patients, I have had a patient that her only complaint was right pinky finger. No trauma, nothing like that. So if you come in like I have a pinky finger that's hurting me, what test would you be running right away?
EKG.
I'm getting an EKG right away. Yep. So our ovaries, I don't know where they're saying our referred pain from our ovaries is, because I feel like that's.
Sorry, did you say it was the right pinky finger or the left pinky finger?
Sorry, left. And I was holding up my left. It might look like right on your screen, but it is my left.
Okay, I was like, wait a minute.
Sorry. Right shoulder for liver. And sometimes in the shoulder blade with the liver as well. Sometimes people with bladder issues, you can see that they can complain of almost like perineal pain, and that can all be coming from the bladder. So chronic pain, this is going to be 3 or more months. We don't really understand why some people will have chronic pain, but we do regular modalities that we would for pain, and they're not getting any better. Once it gets to this point, there's no protective purpose for this. It's something is going wrong. So we're seeing a dysregulation of either that nociception or how that pain is being modulated. That neuroplasticity might not exist. So that maintenance of pain is just going to stick there. Anytime a patient lives in chronic pain, I think we can definitely say that there's going to be behavioral and psychological changes with a huge component of depression and anxiety. So neuropathic pain, this is going to be some kind of dysfunction of the nervous system. These you're going to hear, they describe it as burning, shooting, shock-like, or tingling. Where would all of these words go in your SOAP note?
Neuro.
So definitely in my ROS under my neuro. Where else?
Objective.
So these aren't going to be objective because they're all coming from.
You would write what they came in complaining of, like their
Where do I write that?
Subjective.
What part of my subjective?
Their complaint.
Complaint.
It could be part of their complaint. Do you guys remember OPQRST? Nobody? We just did it.
Quality.
Yeah, so if I'm asking about my Q, tell me how is the quality of your pain? This is definitely what I'm looking for. Do they describe it as constant and dull, or is it burning, shooting, shock-like, tingling, sharp? That would all lead me to think more along the neuropathic pain line. So peripheral neuropathic, this means that we have injured nerves in the periphery that become hyperexcitable. If it's central, then we're going to see some kind of lesion on the central nervous system, either the brain or the spinal cord, and those neuroplastic changes are going to happen within the brain or spinal cord. With specific and non-specific spinal pain, so this can be patients of all ages have chronic recurrent back pain. I think it's now up to like 75% of our population or higher is going to have chronic low back pain at some point in their life. We have myofascial pain syndrome. So this is when they have injury to muscle, fascia, or tendons, and they'll complain of just a deep aching, localized to generalized pain. Chronic post-op pain, those plastic changes within the peripheral and central nervous system are going to contribute to allodynia and hypersensitivity. Cancer pain is kind of its whole own beast, and we treat it completely different, especially when they're at end stages, because we can have cancer pain from pretty much every angle, right? We can see tissue damage if we've got a tumor that's growing and pressing on things. We can see nerve damage if we have a lesion somewhere. So we can have acute, we can have chronic. So we kind of treat cancer pain just as its whole own thing. Central post-stroke pain, the patient can develop hypersensitivity. That just happens to the one half of the body. Phantom limb pain, I think we've all heard of. If you have an amputated limb, that the patient can still feel it. It might become very hypersensitive. Chronic regional pain syndrome or complex regional syndrome, pain syndrome, shortened as CPRS. So we have type 1 and type 2. Type 1 means that they had some kind of injury. Type 2, it means that it happened for some reason that we don't really know. So a complex regional pain syndrome, the patient's pain is disproportionate to what we would expect to see. And they will also have other signs and symptoms to go along with it. And what I mean by that is you could have, let's just say, a surgery on your knee. Okay, so a simple ACL repair. Normally we think 6 weeks and you should be fully recovered. Maybe that patient is still having severe pain in the knee, and now they're getting temperature changes where if we feel the right side, it's hotter than the left side, but we don't have signs of infection. Maybe that right side seems very red, especially if they take a shower. A hot shower is going to make it turn very red. Hair distribution will change. Maybe they don't even grow hair on the right leg anymore. These are all signs and symptoms of CRPS, or chronic regional pain syndrome. So that neuropathic pain, so that phantom limb, here's some possible mechanisms. So we can see sensitization happen within the central nervous system, or we can even see pathological changes where different fibers will change, and that nociception of how we interpret the pain signal is also going to be different. Do babies experience pain?
Yes.
Yeah, we have no reason to say that they don't, right? Even though I think it's very, very undertreated. Pathways that are associated with pains are going to be functional in your preterm and your newborn infants. So that means even if you have a preterm baby, if you're poking them with a bunch of IVs and doing central lines and things, these are still going to be painful to that underdeveloped baby. That nociception is going to be functional by only 20 weeks gestation. So these aren't going to be able to tell us that they're having pain, right? So we have to look at all those cues. So we're looking at facial expression. Are they crying? Are they guarding in different body movements? Or are they just inconsolable? Children ages 5 to 18 have a lower pain threshold than adults. And I think it should be children/boys ages 5 to 18 have a lower pain threshold. And I think it's just because I have a son and a daughter. I know the difference in them, but so pediatrics, some of the things that we should be looking for on those cues. So forehead, if they're very furrowed, if they're closing their eyes tightly, raised cheeks, their mouth is usually going to be screaming, right? Opiate use and addiction. So we just talked about how opiates can change the brainstem, and this is going to actually affect how we control our pain signals, right? We also know it changes the limbic system. So this is going to change our emotions. We do know that they can block pain messages, and that's the only thing that we're really going for when we prescribe opiates, but we have to keep in mind that these two things are also going to happen. So how do opiates work? So we already talked about how they're going to bind to that specific cell site, and that certain molecule, antigen and hormone or antibody, it's either going to block it or allow it to come in, right? So what's dependence versus addiction? So we actually have a DSM-4 definition of this. So it's going to say problematic substance use with the term substance dependence. It does not use the term addiction. So using these two terms interchangeably doesn't make sense when we're talking about a diagnosis. I would not diagnose somebody with an addiction to opiates, but I can diagnose them with a dependence to opiates. I can diagnose them with an illicit drug abuse or a drug misuse, but it's never going to be an addiction. And that's because how DSM-4 identifies these things. Substance dependence means that we have a continued use despite the development of negative outcomes, either physical, psychological, or interpersonal problems resulting from use. How many people are on this call right now? 58. Out of, okay, so we'll say I'm 59, we'll round it up to 60. Out of, go play elsewhere. Okay. Out of 60 nurses in this room, how many of us will develop a dependence problem to some kind of substance?
40%.
So at least half of us.
1 out of every 2 of us nurses
Yeah. So
develops.
one of us is definitely.
What did you say?
So one of us is definitely addicted or something right now. Maybe caffeine.
How many people on this call, and you can just raise a hand, have ever worked with a nurse that you thought was dependent on a substance? So I only have a screen of like maybe 12 of you guys up here, and I think everybody raised their hand. How many of you guys reported that nurse?
You
No.
got caught before I did.
Josh is the only one that's ever reported somebody, so nobody worked with Josh apparently.
Well, it was me along with a number of people at the same time, but yeah.
Why would you?
I had
not-
a nurse while I was a charge nurse that was diverting medications. We had to walk her down to the ER and get her tested during her shift. She
Why-
tested positive for opioids.
Why, if you guys knew you had a nurse that was dependent on something, why did you not report them?
Wait, why would you not?
Yeah.
It's not my business.
That goes to dependence versus abuse. If they're dependent, they might require that medication. It doesn't necessarily mean that they're addicted and actually taking it inappropriately.
So look at our definition of substance dependence is defined as continued use despite negative outcomes, including physical, psychological, or interpersonal problems. So I'm just talking about somebody that you feel is dependent. And if you want to interchange it, how many people were working with somebody that they thought was addicted to something? Don't interchange those. But why would you not report that person? And these are real questions. Like we can just have an open dialogue. There's not a right or a wrong answer. I'm curious.
The
Not being
dependency,
sure
yeah.
They were not. You don't want to be wrong.
So the potential of screwing with somebody's career for sure. What did you say, Paul?
Yeah, just like what she said, a dependence is not necessarily like abusing it.
A dependence is. So we're not talking about a chronic pain patient that is appropriately using medications. When we're talking dependence, we're talking despite development of negative outcomes. So this patient has had physical problems, they've had depression or anxiety, they've had relationships go bad, all because of their use. That's what we're talking about when we say dependence.
Person I'm thinking of was, I think, high functioning and wasn't abusing at work, but eventually she started to abuse at work and someone else reported her. But I think it was starting to wreck her home life, and she was able to refrain from the drugs while she was at work. And then it just kind of escalated.
So I will tell you guys, if I had not been reported to the nursing board, I probably would not be alive right now. So the nurse that you guys are all talking about diverting, that was me. And Nick talking about high functioning, I was a super high functioning. I was almost done with my nurse practitioner degree. So I went through my whole master's program before I finally got reported. And I maintain that had she not reported me, I'd probably be dead right now. So next time you suspect it, and I don't know if I was in your guys' shoes too, like, would I just want to run and tell somebody? I am the type of person that I can come right to you and ask, do you have a problem? Is there something that we need to talk about? And I understand a lot of people aren't that direct, but I would rather have it reported and investigated by somebody outside of the situation, like the nursing board or my direct supervisor or somebody, to potentially save somebody's life. And I went through the Can Do program with the nursing board where I spent 3 years being monitored and had to go through rehab a couple of times, because anybody that knows anybody that has any kind of dependence knows that usually doesn't work the first time around. I got caught and I did not stop using because I thought I was smarter than everybody. And it wasn't until I grabbed a vial of what I thought was fentanyl and shot up 500 of ketamine, and they found me in the bathroom, did I finally wake up and think, I might have a problem. I should probably actually go to rehab. So been there, done that, kind of close to home when we talk about all this stuff. But just giving this talk like I do when we talk about opiates, kind of an easy segue for me to tell you guys about it. But I've had students come to me about their problems and we were able to get it under control before they had to go through what I went through, before they had to risk losing their license, before they have to risk giving away their livelihood. So no judgment if anybody ever needs to talk, but I always like to throw it out there. So then this was our next line that we didn't get to. So most of us do refer to this as addiction, but know that they are not technically supposed to be used interchangeably. One is a true diagnosis and one is just kind of a crappy term that we throw on people, right? So addiction, this can happen when we don't have the presence of any kind of physical dependence. This can happen when our bodies start to adapt to a drug and defined by our body's tolerance to a medication, or if we go through withdrawal when we don't have the medication. So tolerance, this is reduced response to the same drug. That means you could start off by taking a 5 milligram oxycodone and that controlled your pain. Fast forward 3 months, now it's taking 30 milligrams. Dependence is your body's physical need for that more drug when you don't have it. And this will be despite having pain. Dependence is going to happen when you're misusing it for reasons other than what they are prescribed for. Then we fall into that dependence. So withdrawal is going to be the period when that person that is addicted to the drug stops taking it and they start to have uncomfortable or painful symptoms. Notice that we don't say they die, right? Or they're going to start substituting with a similar substance to avoid those side effects of withdrawal. So this would be your patient that was prescribed oxycodone for a long time, can't get it anymore. Now they're going to the street and taking fentanyl. So here's your criteria for substance dependence. They're going to have 3 or more of the following at any time during the same 12-month period. So all of us that just think that we're occasional wine drinkers just trying to get through NP school, if we have 3 or more of these in a 1-year time period. So this would be tolerance. We have to drink more to get that same buzz. Withdrawal, when we have symptoms when we don't have it. We have to take in larger amounts over time. We have a desire, even though we are trying to cut down or stop. We spend a lot of time trying to get to that drug or alcohol. We have disturbances in our social, our work, or our recreational functioning. We know it's doing damage to ourselves, but we still use it. Any one of those 3 in a 12-month period, you can actually throw yourself into the substance dependence DSM criteria. So opiate use disorders, this is going to be when they're taking larger amounts or taking drugs over a longer period of time than intended. We have a persistent desire or unsuccessful effort to cut down or control that opiate use. We spend a lot of time trying to get that drug or recovering from its effects. We crave it. We might have problems at work, home, or in our relationships, or we continue to use it even though we have social or interpersonal problems. These patients will start to give up activities because of opiate use. They're not going to keep engaging in all of the activities or recreations that they used to. They will use opiates in a physically hazardous situation, i.e. your trauma nurse that is going to go take opiates right before they run their trauma. Your continued opiate use despite ongoing physical or psychological problems. They develop a tolerance or they experience withdrawal. Questions on that one?
If you work with pain, how do you keep the patients from becoming addicted if they're on chronic pain meds?
Education. I think I am probably in the absolute right position to talk to my patients about it. That's why I work in pain management. I was very, very poorly controlled. So my addiction all started after I had a degloving accident. I had an ATV roll over and rip off my right foot. And my pain was not well controlled after my accident. In the hospital, I was very well taken care of because I was one of their own. But when I was sent home, they were like, oh, here's some tramadol. So when I went to work, I started supplementing with, oh, I used to take Percocet. I can take your Percocet. So I think I'm in the best position to educate patients of what that can look like long-term. Did I ever plan on becoming addicted to opiates? Of course not. I had never even touched them. I was prescribed them until my brain physically changed. I mean, I had always been a drinker and I could drink socially and be totally fine. I was never anywhere close to becoming an alcoholic. and I could take it or leave it. But once I had enough opiates in my system, I think my brain was physically and chemically changed. And that's what I try to educate my patients on, that if I do this long term, this is what's going to happen. I'll be honest, one of the biggest ways that I can keep dudes off pain meds is I talk about how it affects their sex drive. And that seems to make them be like, oh, I don't really want opiates anymore. So the more information that you can give, I think the better. And I just think that I come from a standpoint where there isn't judgment. I know what chronic pain looks like. And I'll do anything and everything that I possibly can to try to get rid of pain. And that's why I'm like really big on neuromodulation. These are things that were never offered to me when I had my accident, that I didn't know you could do spinal injections and get rid of my foot pain like that. I didn't know about any of that stuff. So just the more that I know, I think the more that I can teach my patients.
Thank you.
You're welcome. Y'all ready for a review? Did we get too heavy? I've lost you all. Ooh, we have a new faculty portal. This looks all different when I log in. Does it look different when you guys log into your LoudCloud now?
I think so.
Oh, mine totally changed from just earlier. This is weird. Just the login. Everything else looks the same. All right, so I told you we're going to go through 100 questions on the midterm. That's not entirely true because a lot of them I just threw into your PowerPoint. So hopefully you were paying attention on that. And I'll skip over ones too that I think that we have talked about. I'm not screen sharing, right? Nobody can see what I'm looking at? No? Okay. Somebody tell me what the Samoji effect is.
That occurs in diabetics when at nighttime, if they experience hypoglycemia, their body will attempt to increase the blood sugar and they'll wake up in a state of hyperglycemia even though they haven't eaten anything.
Very well put. So it's our body is basically overcompensating for a low blood sugar, will make us have too high of blood sugar.
It's when we had too much insulin before bed.
That's yes. What does our body use to take something across a cell membrane? It needs something to actually transport like enzymes or electrolytes. What does it use to actually transport across that cell membrane?
TP.
Protein.
Whoa, Carissa, is that you echoing so bad? But you had the right answer. I just don't want you to say it again. So Carissa said proteases. So proteases are what's going to get everything across that cell membrane. We have a part of our cell that works as that is going to stop water soluble molecules from crossing over. What part of the cell is that?
Lipid bilayer.
That is your lipid bilayer. So remember, that is not water permeable. What do we mean when we talk about in the cardiac cycle? What is that absolute refractory period?
Where nothing can happen at all.
Yep. So it doesn't matter what stimulus we throw at the heart, nothing can happen during that absolute refractory period. Exactly. What do we need to get fluid to move from the arterial end of a capillary into the interstitial fluid? What do we need?
Hydrostatic pressure.
We do, in fact, need hydrostatic pressure. If we have a cell that adapts by replacing one type of cell with another type of cell, what is that called?
Metaplasia.
Metaplasia, absolutely. So when we talk about a woman's breasts during pregnancy, they're going to get bigger. That is happening because of what kind of cellular process?
Hyperplasia?
Hyperplasia, exactly. If you had a patient that had, let's say that they had an abdominal surgery and they had a lot of blood loss. So they had to have multiple blood transfusions. What condition do I need to monitor them for?
Hypercalcemia or
Hemochromatosis,
You got it, Beverly. Do it.
hemochromatosis or something like that.
You were so close. I thought you had it. Hemosiderosis. Somebody tell me what hemosiderosis is. Something we have never talked about, Dr. Tyler. So it's when after a lot of blood transfusions, our body and our organs start to accumulate too much iron. Hemosiderosis. So we need to monitor them for that. All right, my patient has a sodium of 164. Why are they having the symptoms that they're having? Tell me first, what would you expect to see clinically?
The cells are, the cells are shrinking, leading to confusion.
There you go. So leading to confusion. What else can we see?
Dehydration.
Yeah. So confusion, convulsions, we can even see cerebral hemorrhage, remember? Or even coma. And that's all happening because the cells are shrinking. Why are the cells shrinking?
Too salty.
Because we're salty? Yeah, we have a lot
Water
of
follows salt. It's osmosis.
Exactly. So we have a really high sodium in our blood vessels. And what follows sodium?
Water.
So our cells are going to shrink. And that's why our cells are even shrinking in our brain. So that's where we'll see the confusion. All right, I'm going to give you an ABG. You ready? 7.28 for a pH. Bicarb is 28. Your CO2 is 60. What are they?
Respiratory acidosis?
Acidosis.
Yes, ma'am. We talked about a genetic syndrome where the patient will be really short in stature. They're going to have that webbed neck. What is that called?
Turner syndrome.
Turner syndrome.
Turner syndrome. Yep. What chromosome?
X.
Yeah, so it's an X-linked chromosome disorder. If a patient has A and B alleles, what's their blood type? I hate that question.
AB.
Yeah, so if they have AB alleles, they are AB blood type. Why would one twin get asthma and the other not?
Epigenetics.
Epi2 something.
That was a very quick, correct response, yes. What cells do we send in if we have a parasitic invasion?
Natural killer.
Eosinophilic.
Yeah, your eosinophils. Parasite ends in E, eosinophil, parasites. We can have neonates that don't have a very good inflammatory response. Why is that?
Didn't get breastfed.
That could be a reason, yes. That's not a.
They're transitioning from there.
Passive immunity.
Yeah, so that that immunity might not have built up. How do we get that immunity?
These are really immature.
Yeah, immaturity, but why does that affect their inflammatory response? Do you guys remember what the complement system is?
Mm-hmm.
Yes or no?
Yeah.
What's the complement system?
Classical pathway, all that stuff.
Our neonates, do they have all of that yet?
No.
No.
No, so that complement system is going to be lacking. We just talked about this in my class on Monday night. If you have a student nurse with you and you're going to go do a wound debridement, they're going to grab a whole bunch of supplies. They're going to grab gauze, they're going to grab tape, they're going to grab hydrogen peroxide. What are you telling them to put back?
The hydrogen peroxide.
Wow.
It kills all the good tissue too.
Yes, do not use hydrogen peroxide on anything that is not healthy tissue because it will kill it. It will even kill healthy tissue. What do you want them to use instead?
Saline.
Normal saline.
Yeah, we just want normal saline, right?
You also use sterile water.
Yeah. Just not hydrogen peroxide is really all I want you guys to get out of that. My class on Monday night, I wish I had saved the picture, but I had one of my students show me a guy had his throat slit and he didn't think it was that bad. So he went home and poured hydrogen peroxide on it. And by the time he got to the ER, you could see his entire trachea.
Damn.
So don't pour hydrogen peroxide on your slit throat. Duh. Tell me, why do we give some vaccines orally? Why are some injection? Why do we have different routes?
The way they're absorbed into the body.
What does it do?
Because of the B cells that are.
Did you say oral vaccine?
Yep.
It's a polio, right?
What's that?
That's a polio vaccine, right? The oral.
There's oral. Is polio oral? There's also what
Because I
else?
remember, like, when I was a kid, getting that polio, like something through the mouth.
Yeah, and I can't even think of one off the top of my head if polio is one. But yeah, there is oral vaccines. So Angela on the chat just told you guys, so it's going to impact lymph areas and how they respond. It's actually stimulating different lymphocyte areas of our tissue. And how they impact the different lymphocytes, that's going to depend on how we get a cellular and that humoral immunity. So it's all how they affect lymphocytes. If a patient has a hypersensitivity reaction that is IgE mediated, how are you going to treat them?
Antihistamine.
Yep, we need an antihistamine if it's IgE, yes. If we have a type 2 hypersensitivity, what is happening at a cellular level with a type 2?
Memory.
Okay, so expand on that. So with memory, we've developed what?
Antibodies.
So antibodies are going to do what?
They're going to bind to the antigens and make complexes.
Exactly. Yeah. So those antibodies that we've built up are now going to bind to that antigen. And that's how we're going to get a type 2 hypersensitivity. Which one's going to be quicker, type 1 or type 2?
2.
1.
1 is going to be a quicker. So we give Rogam to who?
Mom.
Babies of RH.
Why?
Negative, mom.
Negative.
Why do we give Rogam?
Because their blood could be incompatible with each other.
Which could cause what?
There's antibodies will attack a second pregnancy. They'll cross over the placenta and destroy the fetus.
Yep. So we would see what kind of anemia?
Hemolytic anemia.
Hemolytic anemia, exactly. What do phagocytes take care of for us?
Bacteria.
Yep. Tell me, what is an exotoxin?
They're created in gram-positive cells. It's like the bacteria that goes in and causes harm.
Yep. So exotoxins are what's going to be released when we see that bacterial growth. Exactly. Why, if we're stressed, is my immunity going to be lower?
Cortisol level is going to be higher.
Yep. So your helper T cells are going to be suppressed. So that's going to decrease my cortisol levels. Exactly. Why do we get really cold and clammy when we're stressed?
We have epinephrine that's released that causes vasoconstriction.
Absolutely. Yeah. All those blood vessels are going to be constricted. How much of our blood can we lose before we go into hypovolemic shock?
15%.
15%. Who's M23445?
My name's Brianna.
Brianna, you've been studying. I like it. What's our telltale sign of neurogenic shock?
Bradycardia, hypotension.
Because of what?
Vasodilation.
Vasodilation, exactly. If I have 4 patients assigned to me, I've got a septic shock, a hypovolemic shock, an anaphylactic shock, and a neurogenic shock. Who am I going to first?
Anaphylactic.
My anaphylactic, for sure. That's going to be deadliest quickest, right? They're all deadly, but that's going to be the deadliest quickest. That's actually a great question that you might see on a board exam. I'm not saying you will, but I think it's a really good one because it's a good way to kill somebody if you get it wrong, right? How do we know that a septic shock person is having a good immune response?
My blood cells count.
White count.
Yeah.
The lactic acid.
So, but if we know it's a good immune response, we know that that white count is going up. Specifically, what part of the white count?
Neutrophils.
Our bands, right? We want our baby ones to start getting out there and maturing. Why, if we see a kid in shock, why will their spleen and their liver enlarge and they develop weird edema?
Systemic vasodilation.
So systemic,
Or
so cardiogenic shock.
cardiac output.
So decreased cardiac output, so the blood's not.
It's pooling.
Yeah.
Yeah, pooling.
So we'll actually see venous congestion. Exactly. If you had a kid and you were going in and you were doing your assessment on them and your cap refill is 4 seconds, what is absolutely on your differential diagnosis list?
Shock.
Shock. What's your main goal if you're treating a patient in shock?
Improve cardiac output.
Wow.
Increased perfusion.
Also urine output.
We want what?
Improve oxygen supply.
Decrease.
So how do I improve oxygen supply?
Tissue perfusion.
I definitely want tissue perfusion, but how am I doing that?
Avoid hypoxia.
Increase perfusion.
How am I
Yeah,
getting,
supplemental
how am I getting
oxygen?
optimal perfusion? I need to increase what?
Blood pressure.
My supply, but decrease my what?
Cardiac output.
My demand, right? So we need a better supply than demand, because in shock, those are going to be opposite of what we want them to be. If we have a burn patient and, sorry, if we have a child that's a burn patient, why do we know that they're going to have a higher morbidity and mortality?
Less body surface area.
What does that affect?
The
Low glycogen level.
Yeah, they're not going to have the glycogen stores that an adult has.
Hypoglycemia is prominent.
Give me signs and symptoms of shock in a newborn.
High-pitched crying.
Irregular heart rate.
Hypoglycemia.
So I'll take irregular heart rate, but is it going to be a high or a low irregular?
Right.
Yeah, it's going to be a low heart rate. What else?
Hypoglycemia.
Temperature.
Hyper or hypo?
instability.
Hypo.
Hypoglycemia. What else? What else can they not regulate?
Their temperature.
Temperature. So those are going to be my 3 big ones with newborns. Decreased heart rate, temperature is not going to be regulated, and they're going to be hypoglycemic. How do kids compensate for cardiogenic shock? There's a bunch of different ways. 4 different ways that I want you to name all of them. I just want one. Start with one.
An angiotensin system.
Okay, so we're going to have that adrenergic response. So what's that going to increase?
Fluid.
Heart
Heart
rate.
rate,
Heart rate,
cardiac output,
heart rate and cardiac output. Okay. What's the next one?
Respiratory.
Blood pressure.
vasoconstriction,
So we're going to vasoconstrict, which is going to do what to our blood pressure?
Increase.
Increase it. Yep. Do you guys remember your splanchnic arteries? Everybody looks down. No. What's a splanchnic artery?
Those are the ones that will restrict in the event that you have shock. So they keep the body, like shunt everything to the center.
Exactly. Yeah, our splanchnic arteries are going to divert everything away from our extremities, away from our skin, and put it to our kidneys, our heart, and our lungs. So we've got our splanchnic arteries. We talked about our blood vessels constricting. We talked about our RAS system, right? Our renin-angiotensin aldosterone system being stimulated. And then we are also going to have that adrenergic response. And that's going to help increase our heart rate and increase our cardiac output. So those are the 4 ways that kids can compensate for cardiogenic shock. In a carcinoma, we will see abnormal proliferation of which tissue?
Epithelial.
Epithelial cells. If we can no longer show differentiation at a cellular level, what's that called?
Anaplasia.
Anaplasia.
Yep, anaplasia. I have an H&H of 7.3 and 15. Give me some differential diagnoses.
Anemia.
Okay, so anemia, be more specific.
either blood loss or loss of production.
Okay,
Iron
so
deficiency.
chronic bleeding. We talked about blood loss, right? Who was just talking?
Iron
So they're not either absorbing iron correctly or they're not getting it enough, right? So if I have a really low H&H, I better have chronic bleeding on my list. I better have malabsorption of iron or malnutrition. Tell me some ways that you can avoid getting cancer.
Diet, exercise.
Don't smoke, don't drink alcohol. Occupational hazards, kind of restrict those.
Live in a bubble.
Even then you know your air is going to become toxic and you're going to get cancer from your own air. So I don't think
Have better genes.
there you go. All right.
Eat your vegetables.
I liked all of this. What kind of cancer do we see that is linked to a congenital malformation syndrome?
Wilms.
Wilms tumor, yep. If you diagnose a child with AIDS, what are they at high risk of developing in addition to?
Opportunistic infections.
And?
Non-Hodgkin's lymphoma.
Non-Hodgkin's lymphoma, yep. If we've never been exposed to some kind of allergy, what cells do we have that can still go in and get rid of tumor cells for us?
Natural killer T cells.
Yep, our natural killer cells, yep. Why do our lymph nodes become bigger and tender when we're exposed to some kind of infection?
Proliferation of the B cells.
Yes, so B lymphocyte proliferation, exactly. You have a patient that comes in, their liver and their spleen are enlarged. They have a very bronze-colored tan skin, and they're having dysrhythmias on the monitor. What do you suspect?
Failure.
Hemolytic anemia.
Addison.
Hematochromatosis.
Yeah.
I would suspect a hemochromatosis, yes. I liked all of your answers, though. You guys were all onto the right track. Patients that, well, first somebody tell me what's polycythemia vera.
Increase
I remember
everything.
it's the rash you get when you get out of the shower.
Increase red blood cells.
Yeah, because you have too many red blood cells, right? Why will a patient that has polycythemia vera become confused or disoriented?
Viscosity is increased.
Yeah, that blood viscosity, our brains don't like that viscous blood, right? I am going to give you five patients. Heat stroke, a severe pancreatitis, a term delivery, HELP syndrome, or a snake bite. Who of these are you worried about developing DIC?
Help.
Help.
Snake bite.
Snake bite.
Heat stroke.
Help.
Help.
Okay, we got HELP, we got heat stroke, we got snake
Everybody
bite.
but the term delivery.
Everybody but the term delivery. Good job. What does the collagen in the clotting process do?
Stimulates the extrinsic clotting pathway.
Activate platelet.
Yeah, it's going to activate the platelets. That's collagen's whole role is to activate those platelets. How do you diagnose somebody with ALL, acute lymphocytic leukemia?
30% lymphoblasts.
In the
Blood.
Bone marrow.
blood or bone marrow. Yep. What virus do we know is linked to Burkitt's lymphoma in African children?
Epstein-Barr.
Epstein-Barr.
Give me some signs and symptoms of an early leukemia.
Bone pain.
Bone pain, absolutely.
Lymphadenopathy.
I didn't, you guys were, somebody say another one.
Anorexia.
Anorexia, bone pain, and
Enlarged lives.
say that again. I think it was Beverly.
Bruising.
Bruising, yes. Those are my three early detections of leukemia. What's the most common cause of insufficient making of red blood cells in our kiddos?
Decreased iron.
Yeah, we'll see an iron deficiency. So that's going to be your most common in kids. G6PD deficiency is what type of inherited disorder? What is a G6PD deficiency?
Glucose 6 phosphate something.
What is it? What is it though?
Fava beans.
Hemophilia.
You can't protect your red blood cells from being destroyed. They get hemolysis because you can't make NPH or something.
Okay, so what type of inherited disorder is this?
X-linked.
X-linked, yeah. If you had a patient that came in with a microcytic hypochromic anemia, how is one way that we could potentially cure this patient?
What was it? A microcytic?
Microcytic hypochromic.
Iron.
Well, it B12. Sorry.
Nope. Can actually cure the patient this way. It's a certain type of transplant.
Bone marrow?
It's actually a cord blood transplant. For microcytic hypochromic anemias, we would need to do a cord blood transplant.
Is it also not an iron deficiency, microcytic hypochromic, or no?
It is not specific to that, just a microcytic hypochromic. What type of inherited disorder is von Willebrand's disease?
Coagulation.
What'd you say?
Autosomal dominant.
I think it was Brianna. Say that again.
Autosomal dominant.
Yep. So von Willebrand's is an autosomal dominant. All right, you have a kid that comes in. He is pale, he's fatigued, he's got a fever, he's got petechiae. Give me some tests that you're going to order right off the bat.
CBC.
I want a CBC. What am I looking for?
Hemoglobin.
Hemoglobin.
Anemia. Yeah.
I'm looking for an anemia, maybe an infection. What else do I want?
X-ray,
What am I x-raying?
chest,
Okay, what else?
Would you CT the head?
TMP.
I'm not really worried about a head with, because that petechiae, that makes me
Can you
not
do a
worried
blood
about it.
smear?
What am I looking for?
Can you do a blood smear, or is that too advanced?
Yeah, I wouldn't do that right away. There's a couple of things I want to do first.
Renal function test.
Wanting to look at whether or not they could clot
So I'm
because they've
looking
got
at-
the petechiae.
Coagulation.
Shayla, tell me what you ordered.
like a BUN and creatinine.
Yeah, so I'd want renal function because we're worried about red blood cell destruction. Where do I make those red blood cells?
Bone marrow.
Bone marrow.
So what do I want to biopsy?
Bone marrow.
Yeah. Um, can cortisol, is cortisol lipid soluble?
yes.
Yes.
Yes. Come on, I give you guys a 50-50 one. How is it that our TSH works on our TH when levels are high or low? What is that an example of?
Negative feedback.
Yep, negative feedback.
Primary or secondary.
Just negative feedback. What tissue are we targeting when we release prolactin releasing factor?
Mammary glands.
No. We need to target something else first.
Hypothalamus or the pituitary gland?
Yeah, it's our anterior pituitary gland specifically. So prolactin releasing factor is going to target the anterior pituitary, which will then target your mammary glands. It's a hard word to say, kind of like memory. If you have a diabetic come in, they have not been taking their insulin, they've been out for several days, their sugar is really high. What is your biggest concern electrolyte wise?
Potassium.
I liked that. Everybody said that. What hormone do we have that's going to stop growth hormone?
Statin.
Yep. Don't say it as a question, say it as an answer. What's the answer?
I just don't know how to say it.
Somatostatin.
There you go.
What does our adrenal medulla secrete?
Epinephrine.
Epinephrine.
Epinephrine, yep. What do my sodium levels look like if I have an SIADH patient?
Low sodium.
What does my serum osmolality look like?
Low.
Everything's low. If we have a patient that has DI, diabetic insipidus, and no, sorry, okay. What form of DI will we cause if the target cells for that ADH has an insensitivity?
Nephrogenic.
Yeah, so it's gonna be sorry, I didn't really know how to word that, but it'd be a nephrogenic diabetes insipidus. Give me some signs and symptoms of a thyrotoxic crisis.
Everything's high. Tachycardia, hyperthermia.
Yep. So high heart rate, my temperature is going to be really high as well. Exactly. If I had a patient that came in DKA, and they also said that they've been having just overall flu-like symptoms for the past week, what do those two things have in common when it comes to insulin deficiency?
Infection is one of the most common cause of DKA patients.
So what happens?
Basically, the body goes into fight or flight mode, then insulin, how do you say it? Resistance produces, and you have more glucose in the system.
Yeah, so we're just not going to have enough glucose either, right? We're going to start using up our fatty acids. We're going to go into what type of acidosis?
Metabolic.
Going to go into a metabolic acidosis.
They stop eating too. So in a lot of cases, the patients stop taking their insulin because they think, oh, I'm not eating, I don't need to take my insulin.
Yeah. Why does it sound like you're in a helicopter, Holly?
Maybe because she is.
I have no idea. I'm sorry.
Do you have a fan blowing on your microphone?
No, I'm just in my room.
It's a very loud room. What is calcitonin's job do?
Push calcium into the cells and decrease the level in the blood.
Exactly. What does it mean when we say a patient has pan anything?
Everything.
Oh,
Or
Yeah,
everything.
so like a pan, what are some pans that we talked about?
Cytopenia.
Pancytopenia,
Pancytopenia,
pancolitis.
yeah, so it just means everything is low, right? If you were working a patient up for acromegaly, what are some questions that you would really focus on?
how are you sleeping?
Why?
It did serve the sleeping patterns.
Yeah, but why? Think too much growth hormone is going to keep you awake? Stimulate everything? So yeah, if I'm suspecting acromegaly, I'm going to talk to them about their sleep patterns.
Wouldn't you be asking it about if they noticed facial changes?
Yeah, those would all be like my physical ones too. Because remember, when we talked about acromegaly, is that adults or kids?
Adult.
And so what's the difference?
The growth plate is, the onset is later on the age.
Yeah, so those growth plates are closed, so everything's going to be more deformed than just big like we would see in gigantism. If you have a type 1 diabetic, they come in, they're complaining of lightheadedness, they're a little bit tacky, they're pale. What is the most common cause of their symptoms? I didn't word that very well. What's some questions you might want to ask them?
Blood sugar's too high.
So they're kind of cold and clammy.
Just
Hypoglycemic.
hypoglycemia.
Yeah, so what are some questions you want to ask them? Why would a diabetic patient become hypoglycemic?
Have you been taking your insulin? How much have you been taking?
I would definitely want to know that. What else?
Are you eating okay? Nausea, vomiting.
I would definitely want to know that. What else? What else can cause hypoglycemia in our diabetics? Where's my diabetics at?
Infection.
Have you been sick?
I like both of those.
Have you been exercising?
Exercise, yeah. So we can definitely see an exercise-induced hypoglycemia in our diabetics. If we have hypoglycemia and then we have rebound hyperglycemia, what's that called?
Emoji effect.
Smogy effect.
Is there another one? Like Dawn something?
What is the difference between those two?
The dawn phenomenon occurs in everybody to help us get going in the morning.
Yeah.
Release hormones.
And dawn phenomenon, when are we checking blood sugars?
2 to 8 a.m.
Yeah, so it's going to be like early 2 to 8 a.m. The Simoji just means that we've gone too low and our body's overcompensating. If we have a patient that has diabetes, what are some things? So we'll have like maybe a newly diabetic patient and they have no desire to control their blood sugars. What body systems are you going to tell them that they are trashing?
Kidneys.
Vision, retinopathy.
And
Cardiovascular as well.
definitely cardiovascular, but there's
Neuropathy, vision, kidneys.
Sorry, somebody said neuropathy. So eyes, kidneys, and nerves. Those are the three that we're killing right away, right? Not right away, but definitely long term if we don't control them. What happens if you have not enough parathyroid hormone?
Hypercalcemia or hypo. I think it's hyper.
Hypo.
What happens clinically? What do these patients look like?
Muscle spasms.
Muscle spasms.
Mhm.
So bad that they can cause seizures. So we can see muscle spasms, we can see seizures. What else?
Osteopenia or osteoporosis if it goes on long enough.
Yeah. There's one type of spasm that we can see that can be life-threatening.
Laryngeal.
Yeah. And what's another thing that we can see with not enough parathyroid? They can actually asphyxiate.
Ew.
If a person came in and they didn't have really many complaints, but they're saying that all of a sudden their teeth are just eroding, give me some differentials.
Bulimia.
Bulimia.
Yeah, it's just bulimia. We don't need to work them up for anything. They're puking. Tell me some medical conditions that we relate directly back to obesity.
The metabolic syndrome.
Metabolic syndrome, sure.
Diabetes.
Diabetes, sure.
Cardiovascular disease.
Absolutely. What's another big one?
Cancer.
Cancer, yeah. If I was in a car accident and I had a traumatic brain injury and you poked me with a safety pin that was hot and I couldn't tell you if it was hot, cold, sharp, what type of brain damage did I suffer?
Oh, no.
Where in the brain was affected?
Parietal lobe.
On
Okay.
brain?
What did you say, Caitlin?
Midbrain? Brainstem?
She's
Ow.
Temporal.
Pons.
Yeah, it's your
Pons?
your pons is what's going to do that, distinguishing hot and cold, sharp, not sharp. If we have pure motor or pure sensory deficits after a stroke, what type of infarct did we suffer?
Will you repeat it, the question?
Pure motor or pure sensory deficits after a stroke means we had some kind of micro infarct.
Cerebellum.
Nope.
I would think.
Cerebrum.
Pontine?
Nope.
Parietal.
No.
Frontal?
Brainstem.
A lacunar infarct would result in pure motor or pure
said.
sensory. You did say it? I didn't hear
Yeah,
you.
I did. You just didn't hear
I'm
me.
sorry.
My microphone's too far away.
I'm sorry.
It's okay.
So if we had a spinal cord injury and there was damage to upper motor neurons, how would you expect that patient to progress?
Paralysis and then partial paresis.
Yep. So we would see initially they'd be paralyzed, but gradually we would start to see partial recovery. Where do we make CSF?
Ventricle.
Subarachnoid? No.
I think Lori said it. Can you
Fourth
say
ventricle. Or the plexus.
the chorioid plexus? So we're going back to our spinal cord injury patient. They all of a sudden now are complaining of severe head pain and they can't really see straight. What is your next course of action?
Check for a CSF leak.
You gonna do that real quick?
Vital signs,
Raise the head of the
What
bed.
am I looking for in my vital signs?
increased blood pressure,
Yeah. What am I suspecting?
the pressure, the intracranial pressure.
Or
No, I read it somewhere.
or neurogenic shock?
Okay.
Autonomic. No, no.
What part of the brain do we need for cognitive operations to occur? What system is that? Cognition.
Frontal.
What system?
Central.
What system?
Limbic?
Limbic?
No.
That's
Oh, your
Sorry, can you
your cognitive comes from your RAS system. It's your reticular activating system.
Oh, okay.
I feel like we've never talked about that apparently. There's a certain midbrain dysfunction that will cause pupils to be pinpoint and fixed. What dysfunction is that?
Pontine.
Pontine dysfunction, exactly. What can we kind of expect vital sign wise in a patient that has a closed head injury?
Normal?
Yeah, I mean, mostly, but usually we are going to have this tiny little period of unstable vital signs right after a head injury.
Paroxysmal hypertension.
Yeah, just anything that's unstable, but it's going to be really short term and then they'll go back to normal. What did we say about C4?
Breathe no more.
Breathe no more.
No more. So if I had a spinal cord injury at C3, what is my priority assessment?
Airway.
Airway, absolutely. So we talked a lot about folic acid. So we're trying to prevent what with folic acid in our prenatal vitamins?
Spinal bifida.
Neural defects?
Neural tube defects.
Neural tube defects. When does that neural tube close? What week of gestation?
8.
4 weeks?
Fourth week of gestation. That's why we talk about it's really important if you're just trying to get pregnant to be on prenatal, because usually by the fourth week, most of us don't even know we're pregnant, right? So fourth week. So speaking of that, what supplement do we recommend for pregnant women?
Folic acid.
Folic acid, yeah. If you have a patient that has a history of AIDS, they now develop fever, they're becoming clumsy, they're not really walking right, having trouble talking. What treatment are you going to educate your patient about?
Antivirals.
Specifically, there's a certain medication that we're going to talk to them about.
interferon.
No. So these patients are going to be really susceptible to like even a toxoplasmosis. Do you know what medication we're going to give for that?
No.
Oral pyrimethamine. Oral pyrimethamine. So that's what we would give for any kind of toxoplasmosis.
Can you spell that that drug?
It's PYRIMETHAMINE. methamine. Pyrimethamine for toxoplasmosis. What kind of vascular malformation do we see that can often result in bleeding?
AVM,
Yep, which stands for
arteriovenous
arteriovenous malformation. Yep. If they have a positive Koenig and Brudzinski's, what kind of bleed do we suspect?
Subarachnoid.
Arachnoid.
Subarachnoid, yep. What neurotransmitter did we say people with schizophrenia lack?
GABA.
GABA.
Your GABA, yep. What type of mood disorders generally have disorders in that hypothalamic pituitary adrenal system?
Depression.
Yep, your depression. And your antipsychotic drugs also cause tardive dyskinesia. Why?
Because of dopamine increase.
They mimic dopamine. So how do we link that major depression and cortisol secretion? Stress does what?
Increases cortisol.
And cortisol causes what?
Hyperglycemia.
Cortisol can cause inflammation, and inflammation triggers, we think it triggers depression. So cortisol, inflammation triggers depression. So our depressed patients have a decrease in which receptor binding for which neurotransmitter?
Serotonin.
Serotonin, yeah. If you have a patient that has lithium toxicity, what electrolyte do you also expect to be off?
Sodium.
Is it gonna be high or low?
Low.
What nerve fibers transmit our pain impulses?
Delta.
A delta.
Or A deltas, yep. Give me the name of an endogenous opioid.
Endomorphin.
Endomorphin, yeah. You said tonight.
So I fully anticipate at least half of you getting 100%.
Can you maybe just explain that history of AIDS and having fever, spastic, and gait issues? How that was related to toxoplasmosis?
Let me go back to the question, because maybe that's my answer.
That was just so bizarre.
No, they're thinking of a certain infection. Let me go back to the question and see if maybe I gotta help you without reading the question, you know? That's way down there, and I already clicked out of it. Give me a sec, let me scroll. So they have a history of AIDS. They've become feverish, not having good balance, their trouble speaking. So oral pyrimethamine is used, like we'll use it as an anti-malarial. We'll use it for toxoplasmosis. So what we're trying to get from, and if you saw all of the choices, I want you to get that they're, especially fever, we're thinking what with fever?
Infection.
We're thinking infection, yes. And that's my biggest clue with this one. So if you're thinking an infection, right away we know our AIDS patients are going to be super susceptible, right? So we want to give them some kind of antibiotic. And of the choices through this question, I hope that just given the fact that you have a fever, you would go towards this particular medication. And I could replace that with, what's the magic mouthwash one too? I could replace it with any of those antibiotics. I just want you to know AIDS, fever, opportunistic infection, we need to treat them with an antibiotic. And if you get this question and you see the other choices, you'll see what I mean of this is the right answer. I know that really didn't help, but hopefully it helped. It's not like it's going to give you 4 different antibiotics and you're going to pick one. You're just going to pick something to treat an infection. Does that make sense?
So
without just giving you all of the other options.
Yeah.
I don't think if you saw this question, I think you're not going to take them to surgery. You're just going to know, you're going to know what I mean when you see the question. Okay.
Okay.
Treat an infection of your AIDS patients. And that's the only answer that you can treat. Would I go right to oral pyrimethamine if I thought that they had some kind of parasitic infection? Sure. But that's probably not top of my list. I'll be honest.
Got it.
What other questions did I confuse you on? Just the one? That's pretty good because I have to figure out how to reword 99 questions when we go through this. So speak now. You guys got to take the test before I see you again.
I'm unclear with the tardive dyskinesia. So I thought that they had a lot of dopamine. So if we're giving them something that, so I'm confused how they get it. Like, I'm not, like, I get the question, like I get the answer. It mimics dopamine, but I'm trying to figure out, like, if they already have too much dopamine, why would we give them something that mimics dopamine?
So it's not that we're giving them something, it's just why could it cause that?
So if you just naturally have too much dopamine, can you get tardive dyskinesia just without being treated? Or is it always just from a medication induced?
You could, but it wouldn't be called tardive dyskinesia. It would just be, I don't know, tremors and abnormal movements. If we called it tardive dyskinesia, it is going to be just from the medication.
Okay.
If that helped. What else?
There was the one question you were asking about a microsystemic stroke.
Say that again, Lana.
There was one question you were asking about a microsystemic infarct or something that had a sensory or hearing deficit.
So pure sensory or pure motor deficit, you're going to go towards a lacunar infarct. So Angela, yes, there are going to be multiple choice, but remember, if there's multiple, yes, it's all multiple choice, but if there's multiple answers, it's going to say select all that apply. If it doesn't say select all that apply, I don't think you can pick more than one if it's not a select all that apply. It'll be boxes instead of squares, I think. So if it says select all that apply, it's going to be more than one right answer. Only if it says so.
Do I still sound like I'm in an airplane?
Yes.
I'm so sorry. I don't know what's wrong with it. I was just wondering, when we take the test, do we go in through LoudCloud and take the test like after we've opened up the that system that we have to go through, the ProctorU? Do they then watch us
so
go
when
into
when you log into ProctorU, it's going to make you pick the exam.
Okay, so it's actually through ProctorU. It's not on our LoudCloud account. Okay,
Yes.
thank you.
Yes. And you guys have already gone through and like done your password and everything for ProctorU. You're going to log in just fine and not have any issues. Don't make it more stressful than what it already is. Do you guys feel like after that review, like there was a lot of stuff that you knew and you felt fine about it, right? Or if there was stuff that you were like, this is all brand new information to me, you realize that you should study and probably attend more lectures? Yeah. Was there anybody that this was all brand new information?
No.
Okay.
All of it.
I feel like I knew it during that week, and now that we're talking about it, I'm like, I heard of that somewhere, but
and
somewhere deep.
And as long as it's ringing a bell somewhere, I feel like reading the question, paying attention to all of the answers, there's a lot that you're going to be able to work through just with the knowledge that you guys already have gained. Diana, are you new here? She says, are your lectures recorded? So Diana, I am going to upload For lithium toxicity, so your sodium's going to be what, high or low?
Hi.
Low.
It's going to be
Low.
low. You're going to see
Good low.
hyponatremia. So yes, I upload my lectures. I have a Dropbox. If somebody wants to post that in the chat for her, you can go to my Dropbox. I will tell you, I did my midterm review on Monday night for my other class and my video did not convert. So
Oh, no.
everybody was freaking out. So did anybody record tonight's lecture with me?
No.
That sucks. So hopefully your guys' converts, because it was an issue with my computer that I had to spend all day yesterday on with IT, but they did fix it. So I'm going to try to download this right now and then upload it onto the Dropbox, hopefully within it usually takes like an hour to convert. So I will hopefully upload this tonight. If I can't upload it tonight, that means something went terribly wrong and I have to talk to IT again tomorrow. But my goal is to have it uploaded tonight. And then you guys also have your go-to stage where Melissa will upload it hopefully tomorrow for you too. Questions? So it'll be under, I'll have week 7. I'll put on their midterm review on my Dropbox so you guys can find this one easily. And hopefully it's up there tonight. Denise, you might, if you don't have a recording on Dropbox tonight, you might want to send me your voice recording. Or at least all your other classmates will want you to send the voice recording. So, but I will see what happens when we end this and it converts. So go, don't study anymore tonight. You've done enough to your brain. Go enjoy your night and see you all next week. And I'm excited to see your grades.
All right. Thank you.
You're welcome. Bye, guys.
We put our names in to get credit.
Oh, yeah.
Oh, crap. Yeah, hang on. I gotta do that.
Hurry up and do that. Sorry if anybody
Oh.
out before we did that. I really wish I could copy and paste this chat. It would make my life so much easier.
Did you do attendance for our class?
Is there anybody missing from my class? Speak up if you're missing. Nope, everybody's here from my class. Got it. We're good.
Yeah.
Now I can see all you guys on my participants, so my class is easy. It's everybody else's class that I have to go through and send them emails.
So when those extra credit, did they really wait? When did I add those? Because I don't see in the grade book or anything. Did I add them or?
What extra credit? Nobody gets extra credit. What are you
I mean,
talking
like, are you? I mean, why are we writing this our names down again?
Oh, if you're not in my class, but your instructor gives you credit for
Mhm.
being here,
Oh.
I email it. But I keep emailing Dr. Garrett, and is she not giving you guys credit?
Yeah, so she did not give me credit for the past 3 times, and I was like, "Hey, I attended a lecture. I gave my name. What do you want me to do?" And then today I checked my class email thing, and she said, "Oh, thank you. I'll correct the grade." But I don't know. Like she thought I didn't go to lecture because I'm using the lecture points for peer response, and like I alternate that. But she fixed it, but I don't know what's going on there.
So Cassandra, you were the one that emailed me, right?
Yes, I am.
Did you get my email back that I wanted you to check to see if I have her right email? Because she doesn't have a GCU email. I only have an Outlook.
You know what? I actually have been checking my email. Maybe I checked too fast. I didn't see your email.
Yeah, I emailed you back because I even sent the email that I've been sending her because you're on my list for every email that I've sent her. So I don't know if she's not getting my emails or if she's just.
Because I actually opened the class earlier and I do see an email that is there for her, but I don't know if it's the same one you have. Let me see.
It's an Outlook one and I can't find her under my GC, like she doesn't have a GC.
Yeah, it's sabine.garrettshorty@my.gcu.edu.
She still has a student one?
So that's the one I see like on our course material, like the first, like at the beginning of class, but I actually sent her a message through our forum. Like, it was like a private one for her. And then she replied like, couple of days later.
Do you want to do me a favor? Will you put something on the private forum and be like, hey, email Dr. Tyler so she has your email?
Okay, I'll
'Cause
email
I
her.
feel like she's not getting them. And
Okay.
it makes sense because she does have like, it's a weird Outlook one that I have on file for her. That's who I just took it from, our boss who's been emailing. So maybe she hasn't been getting any emails.
Okay, I'll message her and
That would,
I'll
that would
let
be
her know.
great.
Where does the credit go to again? Like
Oh, whose class are you in?
Garrett shortly?
Have you been typing your name in to get credit at all?
Yeah, I have.
Oh, then you're fine. So I've been trying to email Dr. Garrett, but I don't know if she's not getting my emails. Because every day after class, I sit here and write down all your guys' names and send them to her. But
So
Cassandra
for
said
me,
that she,
I've had to actually send a private message to Dr. Garrett Shorty every time I attend. She's like asked me to send her a message to let her know. She said she'll just take my word for it.
oh yeah, somebody get me a good email because I have been emailing her, and I'll even go through and I'll forward all my old ones so that she knows, because I have been doing it and I don't know where they're going. So Paul,
I
just write your name in the
I
chat.
gave you her private phone number, Dr. Tyler, in the chat. I just sent it to you directly.
Oh, okay.
If you need a caller, that's her cell phone number.
Thanks. Carol asked if anybody wants to meet and do a review. I think that's a good idea.
A Zoom meet?
Probably better than nothing.
I'm down.
All right, you guys all done talking to each other because I'm gonna log off.
Yeah.
All right.
Thank you.
Good luck. I'll see you guys next week.
Thank you.
Bye.